Bismillahir Rahmanir Rahim. Welcome fourth year EMP students. This is my second recorded lecture prepared and presented by me, Dr. Khaled Diab. I'm an OB/GYN professor at Ain Shams University Hospital. Hope you find it useful and helpful. I will share with you the following slides that will review an evidence-based updates on clinical management of preterm labor or preterm birth. By the end of this presentation, the students should clearly understand the following ILOs. The presentation will follow through the following heading titles: the condition, which is preterm labor or preterm birth, its causes, its complication, and its three main clinical presentations: either at-risk women for preterm birth, or threatened preterm labor, or established preterm labor. For each presentation, clinical management will be discussed, notably as evaluation and treatment. Preterm birth is defined as expulsion of product of conception after the age of fetal viability, which varies between countries between 20 and 24 weeks, and it ends before 37 weeks. It may or may not be preceded by preterm labor, that's to say uterine contraction. It is further subclassified according to the WHO or CDC or neonatal weight as shown in the figure. It is noted that all preterm birth, mainly late preterm birth, represents 7 to 12% of all birth. The increase of prevalence of preterm birth in the 90s is related in part to the increase in multiple gestation. Almost 1/3 of preterm births are elective, not preceded by labor due to maternal, fetal, or neonatal indication. Most important are hypertensive disorders as preeclampsia and other hypertensive disorders, antepartum hemorrhage, and fetal growth restriction. On the other hand, spontaneous preterm labor represents the majority of preterm birth. 30% are accompanied by preterm pre-labor rupture of membranes, and 10% accompanied by multiple gestation. In this presentation and for clinical management, spontaneous preterm labor will be subclassified into those with or without significant maternal or fetal pathology as shown in the following slide. 4 discrete mechanisms are involved in the pathogenesis of spontaneous preterm labor as shown in the following slide. Although each mechanism has its discrete epidemiological, genetic, and clinical characteristic, that they all share a common final pathway. That's to say, formation of a uterotonic agent that lead to stimulation of uterine contraction prematurely. Preterm birth has a multifactorial interaction as shown in the following figure. To simplify etiology, 1/3 of spontaneous preterm labor are idiopathic. Other 1/3 are associated with preterm pre-labor rupture of membranes, and the remaining 1/3 is related to uterine or extrauterine factors or to cervical insufficiency. Although preterm birth represents about 10% of all birth, yet it accounts for 50 to 70% of perinatal morbidity and mortality. Failure to further lower preterm birth rates is one of the main reasons for the inability to further lower perinatal morbidity and mortality. Perinatal morbidity and mortality are mainly inversely related to the gestational age. The main short-term morbidity are RDS, current icterus, necrotizing enterocolitis, and metabolic changes. Long-term morbidity is mainly cerebral palsy. Rarely maternal morbidity do occur. Apart from psychological and financial impact, most significant is the risk of recurrence. One study showed increased later cardiovascular morbidity in women with previous preterm labors. Preterm labor may be presented to the OBGYN physician either as asymptomatic at-risk women at her preconceptional visit or in her antenatal visit, or she may be presented with either classic symptoms as uterine contractions or lower abdominal heaviness, or with non-classic, non-specific symptoms as backache or excessive vaginal discharge. Symptomatic preterm labor are further subdivided into either threatened or established preterm labor. Needless to say that several maternal or fetal indications may require indicated preterm birth. Preterm birth represent a classic example for conditions whereby primary, secondary, and tertiary prevention strategies are implemented in clinical management. This will be clear by the end of this presentation and will be discussed in details during the later face-to-face session. Shown in this table, various factors that are implicated in the etiology of spontaneous preterm labor. The student should recognize which is modifiable and which is not modifiable. Furthermore, he or she should know how to ask about these conditions in the current or in previous pregnancies. Risk factors for preterm birth may be identified during women evaluation while history taking for demographic data, past medical history, obstetric and menstrual history in the setting of preconceptional care. The most important factor is an unexplained previous history of preterm labor, preterm pre-labor rupture of membranes, or mid-trimesteric pregnancy loss. During pregnancy, added risk factors to be identified are factors in the current pregnancy. Most important is transvaginal cervical length measurements between 14 and 24 weeks, and optionally assessment of cervicovaginal fetal fibronectin level. The student is encouraged to take history relevant to assess risk factors related to preterm birth from every woman, either preconceptionally or during her antenatal care. Note risks may be modifiable, whereby women is counseled to avoid it, or non-modifiable. Furthermore, risk identification will be only of value if there is evidence-based proven intervention that will prevent preterm labor. Discussion of risk factors with evidence-proved intervention will be done in the face-to-face session. As stated in previous slide, all women pre-conception or during early antenatal care should be evaluated for risk factors for preterm birth. Those at risk should be supplied with information and supportive care and should be counseled for intervention with proven efficiency, evidence-based, to prevent or minimize risks of preterm birth. Needless to say, once pregnant, all women should have an early confirmation of their expected date of delivery to help in further management. The most important relevant risk factor for preterm birth are past history of previous preterm birth, preterm pre-labor rupture of membranes, and mid-trimesteric pregnancy loss, and any obstetric history suggestive of cervical incompetence, short transvaginal cervical length at 14 to 24 weeks, and also early detection and treatment for any related medical or fetal condition that may be implicated with induced preterm birth. The diagnosis of short cervix is defined by transvaginal cervical length measurements below or equal to 25 mm at 16 to 24 weeks gestation. Transvaginal sonography is preferred. However, in patients with well-imaged cervical lengths more than 20 mm on transabdominal sonography, transvaginal sonography may be avoided. Cervical length measurements is an insensitive screening test for prediction of preterm birth in multiple gestation. And also, no intervention has been proven beneficial in preventing preterm birth in multiple pregnancies with short cervix. For these reasons, we suggest not performing cervical length screening in these populations. The evidence-based interventions to minimize preterm birth is written in red fonts in the following slides. As regards pharmacological interventions to prevent preterm labor in asymptomatic at-risk women, no role for long-term maintenance tocolysis or prophylactic antibiotic to minimize preterm labor. Yet, the presence of cervicovaginal or urinary tract infection should be therapeutically treated. Low-dose aspirin is of value for prevention of maternal hypertension and fetal growth disorders in related cases. Progesterone supplementation has proven reduced risk of preterm labor by 1/3 in women with previous preterm labor and short cervix on transvaginal sonography. Progesterone clinical forms and dosage are given in the following slide. Progesterone supplementation has been proven of no value in the setting of preterm pre-labor rupture of membranes or after an episode of threatened preterm labor and is of limited value for multiple pregnancies. Few or minimal complications or contraindications are observed for progesterone supplementation in preventing preterm birth. Yet, the pregnant women should be counseled for the proven evidence-based advantage for the specific clinical form and dose and duration based on their selected risks. This should be reviewed by the student in the recommended reading text and will be discussed in the later face-to-face session. As regards surgical intervention for prevention of preterm birth in asymptomatic at-risk women, this will depend on diagnosis of cervical insufficiency, previously known as cervical incompetence, which is a presumed physical weakness of the cervical tissue that results in early preterm labor or mid-trimesteric pregnancy loss. Cervical insufficiency is diagnosed either by classic history of painless recurrent 3 or more spontaneous preterm labor or mid-trimesteric pregnancy loss preceded by cervical dilatation whereby other causes are excluded, or an ultrasound-based diagnosis based on transvaginal short cervix before 24 weeks, or physical examination based diagnosis which is confirmed advanced cervical dilatation before 24 weeks. Cerclage may be done for any of these indications. It is performed mainly vaginally, rarely abdominally. The student is encouraged to read about the procedure. Further discussion will be in the face-to-face session.